A very good morning to everyone. My name is Dr. Monalisa Singh. I am critical care doctorate of national board trainee second year at Narayana Superspeciality Hospital, Havda. We have one student, that's me, in second year and two students in first year. So we are conducting these academic discussions every Monday for the benefit of the students, and our consultants participate to give us nuggets of their knowledge. So today's discussion is on sepsis, surviving sepsis guidelines 2021. My discussion will be part 1 and part 2 will be covered by Dr. Debottam. So let me start. Sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection, as we all know. So the discussion of surviving sepsis guidelines for management of sepsis and septic shock 2021, this is. We have to note that the recommendations from these guidelines cannot replace clinicians' decision making capability when presented with unique patient variables. So the first part of recommendations are for screening and early treatment. For hospitals and health systems, we recommend using a performance improvement program for sepsis, including sepsis screening for acutely ill, high risk patients and standard operating procedures for treatment. It is a strong recommendation with moderate quality of evidence for screening and strong recommendation with very low quality of evidence for standard operating procedure. So this is the new change in the first recommendation. Standard operating procedure has been added. The second point is we recommend against using QSOFA compared to SIRS, MUSE, NEWS as a single screening tool for sepsis or septic shock. It is a strong recommendation with moderate quality of evidence. QSOFA has a good specificity but poor sensitivity. Third point is for adults suspected of having sepsis, we recommend measuring serum lactate. Weak recommendations with low quality of evidence. The lactate is very important. It is covered in the SSC R1 sepsis bundle and also in the sepsis 3 definition. So this is the changes, these are the changes. Changes are there in the first point, as I said, that standard operating procedure for treatment has been added. The earlier statement was we recommend that hospital and hospital systems have a performance improvement program for sepsis, including sepsis screening for acutely ill high risk patients. Others are same. So the next part is initial resuscitation. Sepsis and septic shock are medical emergencies. We recommend treatment and resuscitation begin immediately. It is a best practice statement. For patients with sepsis induced hypoperfusion or septic shock, at least fourth point is sepsis and septic shock are medical emergencies. We recommend treatment and resuscitation begin immediately. That is a best practice statement. For patients with sepsis induced hypoperfusion or septic shock, at least 30 ml per kg IV crystalloid should be given within first 3 hours of resuscitation. For adults with sepsis, septic shock, dynamic measures to guide fluid resuscitation over physical examination or static parameters alone. So after we do the initial resuscitation, we have to further guide the fluid management by dynamic measures depending on the patient's condition. The dynamic measures which we can use are response to passive leg raise or fluid bolus using stroke volume variation, pulse pressure variation, echo. For adults with septic shock, we suggested guiding fluid resuscitation to decrease the serum lactate in patients with elevated lactate level over not using lactate. In our setup, we use lactate and that is the thing that is suggested. Serum lactate to be interpreted considering clinical context and other causes of elevated lactate. It is very important to rule out other causes of elevated lactate. For adults with septic shock, we suggest using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. Notes regarding these initial resuscitation guidelines are: process, ARISE and PROMISE trials used fluids in the range of 30 ml per kg around. Resource limited settings may use pulse pressure variation, more than 15% increase in pulse pressure in response to passive leg raising for 60 to 90 seconds if cardiac output and stroke volume is not available. Andromeda shock study showed the use of CRT versus lactate normalization to guide initial resuscitation. organ dysfunction less and mortality less in the CRT group. Though it was not statistically significant, but it gives an idea that we can use CRT especially in low resource settings to guide the resuscitation. Okay, so next recommendations are regarding mean arterial pressure. For adults with septic shock on vasopressors, we recommend an initial target MAP of 65 mmHg over higher MAP targets. So, various studies failed to show an advantage of higher MAP targets. It is enough to keep 65. Incidence of AF is more in higher MAP groups. So, the change is in 2016, they said we recommend that in the initial resuscitation from sepsis induced hypoperfusion, at least 30 ml per kg of intravenous crystalloid fluid should be given within the first 3 hours. Others are the same. Admission to intensive care. For adults with sepsis or septic shock who require ICU admission, suggested to be admitted within 6 hours to the ICU. Weak recommendation, low quality of evidence. Diagnosis of infection. Adults with suspected sepsis or septic shock but unconfirmed infection recommended to continuously re-evaluate for alternate diagnosis and discontinuing antimicrobials if alternative diagnosis made. That is a best practice statement. A third of suspected sepsis patients have non-infectious conditions. So, unnecessary use of antimicrobials should be avoided. Time to antimicrobials. Adults with possible septic shock, high likelihood of sepsis, we recommend antimicrobials immediately, ideally within 1 hour of recognition. So, strong recommendation, low quality of evidence for septic shock, strong recommendations, very low quality of evidence for sepsis without shock. Adults with possible sepsis without shock, we recommend rapid assessment of the likelihood of infectious versus non-infectious causes of acute illness, preferably within 3 hours. It is a best practice statement. For adults with possible sepsis without shock, we suggest a time limited course of rapid investigation and if concern of infection persists, administration of antimicrobials within 3 hours of when sepsis was first recognized. 15 is adults with low likelihood of infection and without shock, deferring antimicrobials while closely monitoring the patient. So, in 2016 the statement was we recommend that administration of intravenous antimicrobials should be initiated as soon as possible after recognition and within 1 hour for both septic shock and sepsis without shock. So, these are the changes. Now, they are saying for sepsis in which non-infectious causes can be there, we have to do rapid investigations within 3 hours and then we can defer antimicrobials till 3 hours if we strongly suspect a non-infectious cause. Biomarkers to start antibiotics. For adult patients with suspected sepsis or septic shock, we suggest against using procalcitonin plus clinical evaluation for starting antimicrobials versus clinical evaluation alone. So, clinical evaluation is enough. We do not need to use procalcitonin for starting antibiotics in patients with sepsis. 2016 statement, we recommend that administration of intravenous antimicrobials should be initiated as soon as possible after recognition and within 1 hour, already said. And so, this is the thing. So, there was only one statement regarding admission of intravenous antimicrobials in 2016. Now, they have they have made it more broad. So, antimicrobial choice 17. For adults with sepsis or septic shock at high risk of MRSA, we recommend empirical antimicrobials with MRSA coverage, best practice. With low risk of MRSA in sepsis or septic shock, recommended against using empirical antimicrobials with MRSA coverage, because it increases mortality. It has been shown in studies. Empirical antimicrobials with MRSA coverage in patients with low risk of MRSA increases mortality. Risk factors for MRSA are prior history of MRSA, recent IV antibiotics, recurrent skin infection or chronic wounds, presence of invasive devices, hemodialysis. For adults with sepsis, septic shock at high risk of MDR organisms, we suggest to start 2 antimicrobials with gram negative coverage for empirical treatment as compared to 1. For adults with sepsis, septic shock and low risk of MDR organism, suggested using 1 antimicrobial with gram-negative coverage over 2 for empiric treatment. For adults with sepsis, septic shock in which causative organism and susceptibility known, suggested against using double gram-negative coverage. Risk for MDR are proven infection or colonization with antibiotic resistant organism in previous year, local prevalence of resistant organism, hospital acquired healthcare associated infection, concurrent use of selective digestive decontamination, within the last 90 days travel to highly endemic area, hospitalization abroad, broad spectrum antibiotic use. So, in 2016 they said we recommend empiric broad spectrum therapy with 1 or more antimicrobials for patients presenting with sepsis or septic shock to cover all likely pathogens including bacterial, potentially fungal or viral coverage. So, this has been changed. Earlier they recommended blanket coverage of bacterial, possible fungal or viral based on suspicion. Now they are strongly recommending against starting MRSA without risk factors or double gram negative without the risk of MDR infections. So, we have to consider the history and we have to consider other factors before blindly starting antimicrobials. Antifungal therapy. Adults with sepsis, septic shock with high risk of fungal infection suggested using empirical antifungal therapy over no antifungal therapy. Adults with sepsis, septic shock at low risk of fungal infection suggested against empiric antifungal therapy. So, this trial empiricus was done using micafungin, empirical antifungal versus placebo, no difference in outcome was seen. So, it is an important largest and most recent RCT to support this statement. Risk factors of fungal infection, febrile neutropenia failing to defervesce after 4 to 7 days, prior colonization infection, prior exposure to antifungal therapy and comorbidities. Antiviral agents, no recommendations on viral infections. Okay, so why is it so? Following points will clear it. Unclear as to what extent primary viral infection as opposed to bacterial pneumonia co-infection is the cause of organ dysfunction. No evidence of overall effect of neuraminidase inhibitors on mortality with influenza related pneumonia. Desirable effects unknown while risk of undesirable effects as for any antimicrobial. Recently, SARS-CoV-2 responsible for many cases of sepsis due to rapidly changing position related to severe viral infections, no recommendations made as of now. Okay, next is about delivery of antibiotics. Adults with sepsis, septic shock recommended prolonged infusion of beta-lactams for maintenance after initial bolus as compared to bolus infusion. Two meta-analysis supported reduced short-term mortality with prolonged infusions of beta-lactams. Important considerations are drug stability and drug-drug compatibility considerations and cost. PK/PD for adults with sepsis or septic shock recommended to optimize dosing strategies of antimicrobials based on acceptable PK/PD principles and specific drug properties. Best practice statement. We have to consider the following factors: augmented renal clearance, AKI, hypoalbuminemia, RRT, extracorporeal membrane oxygenation. Use of therapeutic drug monitoring is recommended. So, the same blanket coverage statement is there. That was only one statement in 2016 and now we have they have expanded it. Source control. Adults with sepsis, septic shock recommended to rapidly identifying or excluding a specific anatomic diagnosis of infection that requires emergent source control and implementing any required source control intervention as soon as medically and logistically practical. This is the best practice statement. Example: drainage of abscess, debriding infected necrotic tissue, removal of potentially infected device, GI perforation, cholangitis, pyelonephritis, septic arthritis. Studies show source control within 6 to 12 hours is advantageous. For adults with sepsis, septic shock, recommended prompt removal of intravascular access devices that are a possible source of sepsis, septic shock after other vascular access is established. This is the best practice statement. De-escalation of antibiotics. Adults with sepsis or septic shock suggested daily assessment for de-escalation of antimicrobials over using fixed duration of therapy without daily reassessment. Relevant in empiric therapy. De-escalation is generally safe, cost effective, avoids side effects and reduce the risk of antimicrobial resistance. Adults with an initial diagnosis of sepsis, septic shock and adequate source control suggested using shorter over longer duration of antimicrobial therapy. So, we have to do early source control, once the source is controlled, we have to do shorter antimicrobial therapy. Biomarkers to discontinue antibiotics. Adults with initial diagnosis of sepsis, septic shock with adequate source control where optimal duration of therapy is unclear suggested using procalcitonin and clinical evaluation to decide when to discontinue antimicrobials over clinical evaluation alone. So, procalcitonin is useful in de-escalation of the antibiotics, not in starting the antibiotics. CRP is often used in this regard. Procalcitonin is extensively studied. A meta-analysis was done which showed improved mortality in procal versus control, no effect on the length of stay in hospital, and many trials showed antibiotic duration more than 7 days still, hence quality of evidence was considered to be low. No changes as of in these points. Hemodynamic management fluids. Adults with sepsis, septic shock recommended using crystalloids as first line fluid for resuscitation. Strong recommendation, moderate quality evidence. Adults with sepsis, septic shock suggested using balanced crystalloids instead of normal saline for resuscitation. Weak recommendation, low quality of evidence. Adults with sepsis, septic shock suggested using albumin in patients who received large volume of crystalloids over using crystalloids alone. Weak recommendation, moderate quality evidence. Recommended against using starches for resuscitation. Strong recommendation, high quality evidence. Suggested against using gelatin for resuscitation. Weak recommendation, moderate quality evidence. So, we have to use obviously crystalloids as a first line fluid. An important thing is that they are saying we can prefer balanced salt solution over normal saline, and also to use albumin in patients already filled with crystalloids. Points to note are crystalloids are inexpensive. Adverse effects of normal saline are hyperchloremic metabolic acidosis leading to renal vasoconstriction, increased cytokine secretion and concern for AKI. So, there are 3 trials on these fluids: split trial, salt trial and smart trial. Split trial said that balanced salt solution versus normal saline yielded no difference in mortality or AKI, but the patient profile was predominantly surgical with low number of septic patients. Then salt trial also showed that BSS versus NS similar primary outcome including mortality and new RRT, and make 30 was similar in both groups. Septic patient profile was 25 to 28% in salt study. In smart study, it is a single center study. It favors BSS over NS to decrease composite outcome of death, new RRT and make 30, that is kidney injuries. So, this is the study, smart study, which is single center study. It showed it favored the BSS over NS. Gelatin, as we know, leads to anaphylaxis and altered hemostasis and kidney injury, so it is recommended not to use it. So, changes are in point 33. In 2016, they said we suggest using either balanced crystalloids or saline for fluid resuscitation of patient with sepsis or septic shock, and now they are saying to prefer balanced crystalloids. The next is 2016, in this that we suggest using crystalloids over gelatins when resuscitating patients with sepsis or septic shock. Now they are recommending to use crystalloids over gelatin, gelatin is totally out. Next point is vasoactive agents. Adults with septic shock recommended to use norepinephrine as a first line agent over other vasopressors. Dopamine has high quality evidence, vasopressin moderate quality evidence, epinephrine low quality evidence, celepressin low quality evidence, angiotensin 2 very low quality evidence. If norepinephrine is not available, we can use epinephrine or dopamine as first line, but considering the risk of arrhythmias is there. For adults with septic shock on norepinephrine with inadequate MAP, suggested to add vasopressin instead of escalating the dose of norepinephrine. So, start vasopressin when norepinephrine dose is 0.25 to 0.5 mics per kg per minute. For adults with septic shock and inadequate MAP, despite norepinephrine and vasopressin, add epinephrine. So, first we have to start with norepinephrine, then vasopressin, then epinephrine. For adults with septic shock, suggested against using terlipressin. So, terlipressin for septic shock not recommended. Norepinephrine potent alpha 1 and beta 1 adrenergic agonist, vasoconstriction, it increases MAP with minimal effect on the heart rate. Dopamine is a D1 receptor in lower doses, it causes vasodilation in renal, splanchnic, cerebral and coronary beds. In higher doses it is alpha 1 and beta 1 agonist, and the side effect is dose limiting arrhythmias. Epinephrine is potent beta 1 and moderate beta 2 and alpha 1 effect. Adverse effects are arrhythmias, impaired splanchnic circulation and increased lactate because of the agonism of skeletal muscle beta 2 receptors. Vasopressin, endogenous peptide V1 agonism in skeletal muscles causing vasoconstriction, fixed dose of 0.03 units per minute. So, two trials on vasopressin, the VANISH trial and the VAST trial showed. The VANISH trial showed norepinephrine versus vasopressin, there is no difference in mortality. Vasopressin led to lower use of RRT. In VAST trial showed norepinephrine versus norepinephrine plus vasopressin and no difference in mortality. Celepressin, highly selective V1 agonist, non-catecholamine vasopressor. It failed to show superiority over norepinephrine, not recommended. Angiotensin 2 is a natural hormone with the vasoconstrictor effect through renin-angiotensin system. It has also shown no superiority over norepinephrine and may, but because of the physiological effect, it may have a role as an adjunct. Terlipressin has shown adverse effects more, so there is weak recommendation against it. Regarding inotropes, for adults with septic shock, cardiac dysfunction with persistent hypoperfusion despite adequate volume status and arterial blood pressure suggested either adding dobutamine to norepinephrine or using norepinephrine alone. Next point, for adults with septic shock, cardiac dysfunction with persistent hypoperfusion despite adequate volume resuscitation suggested against using levosimendan. So, we can use dobutamine, but in septic patients they are suggesting not to use levosimendan. So, the points are sepsis induced myocardial dysfunction is a major contributor to hemodynamic instability associated with worse outcomes. No evidence supports superiority of dobutamine over epinephrine, both to be discontinued in absence of improvements. Levosimendan, Leopard study showed levosimendan associated with lower likelihood of successful weaning from mechanical ventilation and higher risk of supraventricular tachyarrhythmias. So, these are the points, there are no changes as such. Okay. So, regarding 2016, the fluid statement is only there, which we already discussed, that earlier they said either BSS or NS, now they are saying to prefer BSS over NS. Thank you very much. This was the first part of the surviving sepsis guideline recommendations of 2021. We are thankful to sir and our other consultants for important discussions, and we will try our best to implement this in our practice. The second part of this class will be taken by Dr. Debottam in the coming week. Thank you very much.